you, Professor Basuni. Thank you for the organizing committee for inviting me again this year. I'm going to have my slides. Great. So my task is to cover type 2 endoleaks in 6-7 minutes. I don't have any disclosures. What I'm going to try to cover in the next 6 or 7 minutes is to define what a type 2 endoleak is, discuss the incidence, how to make the diagnosis, and our management techniques, and then give you an idea about the results, and finish with a summary. So to set the stage, type 2 endoleak is categorized as type 2A and type 2B depending on how many vessels are identified. And the incidence in the literature is said to be somewhere between 10 and 20%. Now, as all of you who are performing EVARs, you know that the incidence is much higher during the case, and a lot of these type 2 endoleaks eventually resolve in follow-up. Sometimes patients are labeled as having type 2 endoleak, and that is an erroneous classification, and it should be an unknown type of endoleak. And then I think that most of us would suspect a type 2 endoleak if the sac continues to grow despite everything being sealed proximally and distally. The thing that I want to emphasize is that there is no standard threshold for treating type 2 endoleak, and then this might be something we can discuss in the discussion after the talk. And I'll cover some options and talk about an algorithm. So in our hospital, the patients get a CT scan at 1 month, and then after that, patients are followed by duplex scan. And if the technologists are savvy, they can show you the type 2 endoleak on a duplex like you can see here in this picture. If you are wanting to confirm this, then a CTA or an angiogram need to be performed. Basically, what you're looking for is the most common source is a patent IMA and lumbars. So the first target will be to try to cannulate the IMA through an SMA branch, and then do some coiling. If that continues to persist, then the next step will probably be a direct sac puncture. There have been many authors in the literature that talk about their techniques in doing this, and you can see here some pictures at the bottom that show the direct puncture technique versus doing an endovascular cannulation. The panel E here is when you place the patient on their in a prone position and access the aorta posteriorly with a long access needle, and then you're able to access the sac directly and do some coil embolization. Of course, if all these endovascular techniques fail, then you're left with the dilemma of what to do if the sac continues to expand. And I think some have advocated doing laparoscopy and clipping of the lumbars. I think that the open excision of the graft should be left as a last resort. And obviously, if you're planning to do this, it should be done electively, as the results are much better. We have, as I mentioned, our incidence in our hospital is somewhere around 18% of type 2 endoleaks. And patients are followed carefully, and we've been successful in coiling the offending collateral in most of the cases. However, we've done about 5 explants in the last 5 years due to persistent endoleak and enlargement of the sac. And this is a patient that has had a persistent endoleak, and then we used Onyx, which you can see here. And the problem with Onyx is that it's very difficult to follow these patients, so that should be used as a last resort. This is a picture of the preferred technique, which is to cannulate the SMA and then using slick catheters to get into the offending collateral. Dr. Macaroon, who was on the panel a minute ago, has had a nice article summarizing what they do in Pittsburgh. And as you can see here from panel D, that you can be spending a lot of money trying to coil vessels, and this should be taken into account. This is my next to last slide. I think everybody should develop some kind of algorithm as to how you're going to follow the patients and what are you going to do when you find an endoleak. And typically what will happen is if you identify one, then you need to decide what is the threshold to intervene. There's been a recent paper in the Midwest Vascular about a month ago that talks about aneurysm sac expansion more than ½ centimeter in 6 months or more than 1 centimeter in a year as a solid indication to intervene because in those patients the risk of rupture is pretty significant. So once you develop an algorithm and follow the patients, I think this should be followed, and sometimes you have to get more than one modality to image this. So to summarize, I think for vascular surgeons who perform EVARs on a regular basis, type 2 endoleak is a very common occurrence. It happens very frequently at the end of the case where you see a blush filling the sac even though you have a good apposition proximally and distally. I'm here to tell you that I don't know of any consensus guidelines as to when intervention should happen. There are many people in Europe who think that type 2 endoleak is mainly a benign phenomenon and nothing should be done unless your hand is forced. I think all of us should develop an algorithm for management, and a sac that is growing rapidly is an ominous sign, and these patients should be investigated very thoroughly. Thanks again for the organizing committee for inviting me, and I appreciate being here. Thanks.